Dear all, I'll welcome you all to today's lecture in relation to management of type 2 diabetes according to Australian guidelines. These guidelines were, if you hear, which we call it the Aussie rules, and Aussie rules, Aussie stand for Australia, and Aussie rules in particular in Australia refer to the Australian rugby, but I use it as a تعبير مجازي عن الأستراليan approach. يعني الإسرائيلي الركبي يختلف عن الأمريكان واليوروبيان rugby. Anyway, these guidelines has been put forth by the Australian government body. It's called the Australian National Health and Medical Research Council, which belongs to the federal government Department of Health. The first concept I'd like you to appreciate is our understanding of the guidelines is they are no more or no less than general rules. These rules put the boundaries for your practice field, so one would know when they are really actually going outside that boundary and they have to stop. So it prevents clinicians from skewing away from the field of the Victorian field of management. And it's a fairly wide field. خاصة فيما يخص diabetes, it's not in any shape or form a strict or narrow field. The Australian guidelines is, when they ask me, is it similar to the American or the European? The answer is yes, it is similar to the American and the European and the English, because they are the general rules. However, what's different is the algorithm. Treatment algorithm varies considerably from Australia to America, and that of America is not similar to that of European Union nor to the British, because each country here or continent have their own financial capacity to support this algorithm. وبالتالي same thing ممكن ينطبق على العراق. We need to have an algorithm that the government or Department of Health budget can afford. In this review, we'll review the Aussie guidelines, or as mentioned, the general rules, our algorithm, what's triggered the guidelines to come to the surface, and what's the philosophy behind it, and how we implement it here in Australia. So the objective of these guidelines, when I reviewed the doctrine, it actually it's made me feel like as if I'm sitting with a patient and discussing the basics of diabetes, and that's actually a pretty clever idea. The question, if you can imagine, I'm being diabetic for the first time and I'm asking my clinician, you want me to improve my glucose, how would that impact any long-term complication, my quality of life, vascular complication, or other complication we know, I read in the internet, microvascular complication. Is there a potential harm from the medication you gave me? How would you expect, how we're going to assess my glucose control reliably? And what's your target for a good blood glucose level? And how would that impact my socioeconomic status, and what sort of lifestyle modification you would like me to take? Can I change my lifestyle modification to get rid of diabetes, for example? Is there a role for lifestyle changes or modification in managing diabetes? So these are the points we're addressing these guidelines. The recommendation goes as follows. Yes, we do need to optimize blood glucose because this will have a beneficial effect on the microvascular complication. It either prevent. Now, we've established in these guidelines that there is definitely a benefit, microvascular in terms of alleviating, reducing, or even sometimes reverting some of the microvascular complication. With a rigorous glucose control, you could slow down the progression of microvascular complication. It sometimes could improve it if you have a good 5 years of rigorous control. There's a wealth of evidence with these trials to support that. Now, this is not the case with macrovascular complication was still undetermined because of the ACCORD and BADIT and the ADVANCE trial. The ACCORD and the ADVANCE showed a negative result, and the BADIT was a neutral result. Now, these results were questionable till this moment. يعني حتى بالكود شافوا على اساس ان الهايبوغلاسيميا هي اللي سببت increased mortality، بس هذا غير صحيح لانه within the intensive arm the mortality rate increased in those who did not experience severe hypoglycemia as many as the others in the intensive arm, the same arm who did not يعني who had more hypoglycemic event. بمعنى we don't think it's the hypoglycemic effect. I think it was just a مثل ما قال بعض كثير من الأساتذة just a bad luck result. عامل صدفة بحث. يعني حتى with p-value under 5%, you still can get a surprise that's less than 5%. That's what I could say. So, and I will talk about that in depth as we go along. The target blood glucose, as been questioned, is we aim at a fasting blood glucose between 6 and 8 millimole per liter, and all the way to 6 to 10 after meals in only 80% of the readings. So if you 8 out of 10 readings in the patient logbook, if it's within this target, then we can guarantee that the A1C will be under 7.5. So it's very easy to further qualify the patient blood glucose control when من يعطيك المريض الدفتر مالته يقول لك أنا هاي أرقامي، كل المطلوب تحسب 10 أرقام وتشوف جد إذا 8 من أصل 10 within this range, then the patient is within the target range. And that's by itself it wasn't an easy target to, it was actually a milestone recommendation, I believe, in the managing diabetes, because in the past we used to say 4 to 7 and we were wrong. And the reason why I changed it from 4 to 7, the lower end of this target, they pushed it up to 6. It's 4 to 7, 4 and 5 is actually very close to hypoglycemic level. Now, as we know that the glucometers we use has a margin of error, coefficient of variation, some of them 12, 16%, well, 20%. The old one has 20%, the old generation. The newer generation has about close to 10%. بعبارة إنه level of 4 can be easily 3.5 if you take a venous sample. Now, the glucometers, when they get old, the chemical sensor tend to be worn off, and وبالتالي يبدي يقرأ false high readings. So that's 2 millimole point between 6 and 4. The reason why we push the lower margin to 6, A, it won't affect the A1C, you still can get a good A1C, and B, to have a buffer zone from hypoglycemia as a safety, as a safeguard. Now, the trials that I've chosen here, for example, the BADIT trial, which is funded by the Veteran Affairs Department in the States. Again, this is a public research center, not private, and they chose a very high-risk patient who had a long time history with diabetes, and they dropped the A1C by about 1.5% from a very high figure. But they didn't find any differences in the primary outcome in terms of cardiovascular event or MACE or death from any cause between the intensive arm and the standard therapy arm. And if you look at the analysis they had, and the mortality group or groups, what they found is the hazard ratio goes substantially if the patient has a prior event than those who did not have prior event. It goes much higher, up to 2-folds, in 2 plus. Well, the mean is sitting at 2 of the hazard ratio here. If they are older population, The A1C has hardly any impact on the hazard ratio, 1.2. And the hypoglycemia had a very wide, you could see that the mean is sitting at 3. However, the confidence interval is very wide, fairly wide. And, you know, the FDA nowadays mandates that the confidence interval will be under 1.3. So that hypoglycemic marker is not, I don't think it's reliable, at least in this study analysis. Now, this is another analysis was done to the Vatican where you could see the association between cardiovascular hazard ratio and the diabetes duration. That's when you get a log linear relationship. The longer the that's irrespective with intensive therapy. Now, irrespective of their previous or current glucose control, and what you see that's adjusted for the glucose control, okay? And what you see is that the hazard ratio goes to 3, 6, 9, over 3, 6, 9 years. It goes almost, you know, by the time it hits 15, the hazard ratio starts to cross the 1 margin. So age is the principal, diabetes age, not the patient age in this particular. The duration of diabetes is that perhaps plays a major role in dictating the microvascular outcome of the patient, particularly for those who had historically poorly controlled diabetes. Now, moving to hypoglycemia, acute coronary syndrome, there was all sort of publication in our circulation and trials to look at what there's a potential of increasing coronary syndrome in hypoglycemic event, and there's all sort of different mechanism, increasing factor A and high sensitivity CRP. Was a talk about steal phenomena, and that was done in the cerebral circulation when they noted that during hypoglycemia, the blood flows from the unhealthy circulation favorably towards favoring the healthy non-atherosclerotic circulation, and of course there's increased incidence of death in the bed syndrome. Now, when you have more than one mechanism, then it means that then you will need to look for the most pathogenic one. And what we think is nowadays is actually the principal mechanism that could lead to cardiac death in severe hypoglycemia is the reduced QT dynamicity. So usually the QT adapt to the RR interval length, and that's compromised when you have severe hypoglycemia, particularly for those who have a pre-existing high sugars and only very poorly controlled by insulin hypoglycemia. They are more prone to have the QT problem. So reduced QT dynamicity, we think is the principal mechanism to cause cardiac death in severe hypoglycemia. However, in absolute terms, this is a fairly uncommon. This is not a common. So we should not really scare our patient or ourselves and tell him, okay, he had a hypoglycemia, it means he's going to have a heart attack. That's absolutely wrong. As a matter of fact, in the back in the days, we used to, from the history of the patient, we used to tell them how many times a month you have a hypo. If they told me about once a week, we say, okay, that's indicative of good control. And we were okay with it. But there is a potential harm on the heart, and hypoglycemia, as we well know, it's associated with increased weight, with the poor adherence, with more depression, and symptomatic hypoglycemia are actually very unpleasant. Very unpleasant. The patient tend to let the sugar go up because they don't want to experience it again. So I think this is the main problem with hypos, not the low risk of cardiovascular, very low risk of cardiovascular event. And now, back to our guidelines, it did acknowledge the potential. For the first time, you could see that we need to sit with the patient and set their glucose target. So we individualizing our approach. Generally speaking, as I mentioned, between 6 and 8 fasting glucose and 6 to 10. I think this is a safe margin or a safe range. However, if a very old, frail patient, you might like the A1C to be perhaps 8. Because the last thing you want for the old, frail person to run into hypos and having a fall and fracture their hip. Now, this is two examples. I picked up 76-year-old with type 2 for about 20 years, complicated by ischemic heart disease and CKD. So this is how I like to present the cases, and I would ask you, this is how you teach your student to present the cases to yourself. All of the age of the patient, the age of diabetes, how many long, any complication. This is the STEM. Okay, and that's consistent throughout my presentation. So with this fella who is 76-year-old, diabetes for 20 years, ischemic heart disease, CKD, I think 7.5% or even 8 is okay. The other 50-year-old young fella, diabetes age is only 40 years and no complications whatsoever. I'd like to see the A1C under 7. How do I get it under 7? What do I do to my range? I'll tell him or her, I want you to get your target sugar between 6 to 8 before breakfast and 6 to 8 even after meals. At bedtime, for example, I like it at any time to be your range under 8 maximum. So these are the denominators for long-term complication: age, diabetes, duration, and complication. Please incorporate this in your case presentations. Now, I thought I'd stop on the age and the clinical discriminations. How would patient age affect our decision? That is, if we agree that there is the chronological age, the biological age, and the functional age. The chronological age, by that I mean the date of birth. The biological age, how well their organs, how old is their organs, how well they're functioning. So you could see someone who's a 30-year-old or 40-year-old, let's say, and his eGFR is 30 ml per minute, normally above 90. So the biological age of the kidney will be equivalent to those who had maybe 80 or 90-year-old. The other way around is true. Someone who is 75-year-old, for example, with an eGFR more than 90 and he had good muscle bulk. That's terrific. That's the biological age of his kidney will be that of a healthy 40-year-old fella. The functional age, irrespective of the date of birth and how well the organs, some patients are so physically inert and inactive, and they have very poor muscle bulk. They hardly ever do any exercise. They can't really function well. They, apart, I'm not talking about depression. They're just lifestyle. They never been into exercise throughout their life, and they just can't really do much physical activity because they are wasted, or their body is wasted. Sorry, their body is wasted. So when it comes to all these categories and how we assess, in particular the chronological age, and I thought I mentioned this, but in particular in our practice, we don't say, okay, I'm not going to give this treatment to the patient because he or she is very old. This is not a good professional language. But what we could tell the patient is there is no evidence that this intervention for this age group can provide any survival benefit. And I think that's a fairly good argument. You can't, a lot of the trials, the mean age is 65, so it doesn't go beyond 85, just for example. And therefore, we have very low evidence to suggest that, lowering the A1C to 7% in the 90-year-old will improve survival. And the other thing I would tell my patient, so how I tell that to my patient, I tell them that the evidence has shown there's no benefit at your age group, so that's one. Because your life expectancy beyond 85, for example, is limited. الافرج longevity باستراليا هي 80 سنه والافرج longevity بالعراق هي 62 years. فبنقول لما بهالعمر احنا بعد يعني ما نتوقعك تعيش حتى لو ما كان عندك دايابيتس لسنوات طويله حسب القراءات اللي مالتنا بالعراق. The other thing I told them, if someone told me, look, he is 70-year-old, but looks very healthy, or let's say 80 or 90-year-old, but he looks very healthy. And I told them is, well, they apparently looks healthy, but they have poor resilience to minor stressors, therefore limited life expectancy. يعني ممكن يكون هو أموره صحيا apparently looks okay, ولكن أي التهاب يصير أو عارض جسمه ما يقاوم. الاميون سيستم مالته عمره 80 سنه ما يقدر يقاوم اي simple pneumonia. This is another study that showed from the JAMA that showed if you have diabetes, how would that affect your longevity? Diabetes here in these empty circles or white circles. If you were diagnosed at the age of 40, it would be about 6 years of life lost. If you have, for example, if you had diabetes, heart attack, and a tiny stroke, well, which one? Diabetes and heart attacks here, you would have, at the age of 40, you would have lost 20 years, regardless, just across the board. لكن بتقدم العمر من يصير عندك diabetes, for example, at the age of, let's say, 70, you would have lost probably 3 or 4 years, no more. هنا أقصد. إذا عمرك 85, you got diabetes, heart attack, stroke, it will reduce your life by less than a year. لأنه you're already getting to the maximum life expectancy span of humans nowadays. So that's just another way of looking at it. This is another interesting conceptual model, and it shows that the cardiovascular benefit you get from controlling the glucose within target range, it tends to wean off beyond 3 years as time goes by years. And look, if you reach 15 years old, or in this bracket between 12 and 15 years old, the benefit plateaus. And I think this tells the whole concept of macrovascular complication and glucose control. It probably will not improve the cardiovascular outcome, but it just may be prevented from getting worse. This is what I tell my patients. So glucose control in diabetes and established atherosclerosis. Glycemic control has a modest role in reverting atherosclerosis. And it may well prevent the progression of atherosclerosis, and this may well translate into lower cardiovascular event. So there's still a room to control glucose. There's still benefit, macrovascular benefit, I think, at least to prevent it from getting worse. I think this is how I look at it. Our guidelines recommended that every single patient need to check their sugars. As you know, the glucose monitoring is associated with increased incidence of diabetes, of depression, and diabetes burnout or burden. However, the advantage of that is you won't get surprises when a patient gets to check their A1C once a year, and last year his or her A1C was 7%, and it comes to you after 1 year and they put on 10 kilograms of weight and they neglected their health and the A1C is 13%. So if the patient checked their sugars, albeit infrequently, maybe 2 or 3 times a week for those who diet control, for example, they will always stay in touch with in tune with their diabetes and prevent any surprises. Now, back to one of the principal challenges, the A1C in diagnosis of diabetes. 6.5% and above, or 48 millimole per mole, will be consistent with diabetes. We do not rely in the initial diagnosis on one metrics. So either two abnormal, well, it has to be associated with another abnormal readings, such as fasting glucose. If they both above within diabetic range, then you can hand over the diagnosis to the ticket to the patient. If there was a discordance, then you pick up the abnormal metric and repeat it before you tell them. And till now, we don't have algorithm management for the pre-diabetes population. Why did we do that? Because the glucose tolerance has a lot of caveats. It's a cumbersome test. It's lab intensive, requires 3 blood samples. It is a gold standard and will always be the gold standard, but it has his sensitivity is not very impressive, and quite surprising to hear that it only pick up the false normal. The normal test from OGT can be false in 2 out of 10 patients with a sensitivity of 83% almost, and that's not across ethnic groups. That's primarily validated against the Caucasian population. This is another study that showed the A1C above 6.4 has actually confirmed diagnosis of diabetes in about 50% Afro-American, 61% in the non-Japanese, Asian, and so forth, which means it actually increases the diagnosis of diabetes in some ethnicity. But the whole idea is the principle of the study to show you that this discordance between the gold standard test, the OGTT, and the new A1C is an issue is yet to be solved. But we are inclined, as I said, if you have two abnormal, if you have a normal OGTT, you really can't tell the patient that you have diabetes, even with a 6.5 A1C. The A1C has its own caveat that I will mention here. It can potentially have false increase for anything that prolongs your red cell span, anemia, and CKD, and connective tissue disease, and rheumatoid arthritis, and so forth. High triglyceride, heavy alcoholism, excess alcohol use, and opioids. It can cause false low if you have high turnover of cells in pregnancy, hemolytic anemia, and portal hypertension. So the role of A1C is still there in monitoring diabetes because it's been a time validated. It's been embedded in our culture of managing this disease or this metabolic derangement problem. Now, if you look here, and this is one of the caveats that I want to take to A1C. If you look at A1C of 7%, for example, it means the sugar can swing between 123 and 185, and you end up with an A1C of 7. Now, if you pick the let's say number 172 or 175, it actually falls in the A1C range of 9% because it's starts from 170 to 249, and therefore the range that the A1C represent in terms of absolute numbers, it has quite a bit of crossover. It has a bit of crossover. So and this is an indicative of high crude the metric this metric is, and of note, and I thought it's definitely worthwhile mentioning here that it only represents 80% of the A1C reading. Let's choose 8% or 10%. 8% of that 10, so 8 out of 10, will reflect the last 2 weeks, and the rest of it will reflect 3 months. We know why 3 months, because the rest of life is about 3 months. Now, what's your target? As mentioned, under 7%, newly diagnosed, no complication. 7% or even higher than 7% should be okay for those who have severe limited life, severe complication, hypoglycemias, particularly those who have frequent hypoglycemia for a lot of reasons, and limited life expectancy. Setting the timeline for intervention, and when do you do on a completely different note now. We addressed the guidelines addressed when the clinician decide to change one line of therapy to the other, suggesting 3 months and no less and no more than 6 months. Why 3 months? Because we don't want to keep changing, every 2 weeks, every 4 weeks. That's quite confusing. Give the patient, and there are studies that show the patient needs about 3 months to change and adapt to the new medication and change their lifestyle accordingly. And of course, you have the A1C span of 3 or red cell span of 3 months, so you can repeat the A1C here and see what happened after 3 months. And don't leave it beyond 6 months, because you'll end up with inertia. You'll be less likely inclined to change medication. So this is how we look at it: 3 to 6 months before revision and treatment options. However, there is in certain circumstances, if you have someone with really, really bad hyperglycemia at entry, you might need to maybe add second, third line quicker than 3 months. And please note that the patient adherence to diet improves dramatically after they see the physician, more than once initially. So if the communication between the physician and the patient is pretty sound and robust, so there's the A1C tend to drop quite a bit, or the daily glucose tend to drop quite a bit just by changing their lifestyle after they saw you once or twice, and listen carefully to what you've told them. Health economics, and we need to be aware of, as I'm sure you do, about the patient capacity, how much this medication cost will impact their life long term. Some of these medications are costly, and often we need to use a combination. Now, asserting the diagnosis in a newly diagnosed type 2, the guidelines suggested we need to consider LADA, and which patient we check for LADA, latent autoimmune diabetes of the adult. Those who had a postprandial excursion, because they hardly have any C-peptide and they're not as insulin resistant. But we see a lot of LADA and type 1 now who are morbidly obese, and they can have double diabetes. But still, if they eat anything, the blood sugar shoots up. The other group of patients is those who develop ketosis whilst on DKA, whilst on SGLT2 inhibitors. So these two patients I tend to investigate for LADA. Now, pancreatogenic, it's, I think, definitely worthwhile asking the patient if they have any episode of abdominal pain, severe pancreatitis, and so forth. If they're losing weight despite reasonably modest high A1C, unexplained diarrhea, and so forth. That just brings the attention to pancreatogenic diabetes, which, by the way, is it's just going to change your algorithm altogether, because you don't want to give DPP-4 inhibitors or GLP-1 analogs for someone who had history of pancreatitis. You could kill them easily. Another category of MODY, again, if someone had a postprandial excursion with the right family history, and they are antibody negative for LADA. This is my own approach. I check for LADA. If it's antibody negative, they tend to have a good C-peptide. Then I will say, okay, could that patient be MODY? Now, the family history varies nowadays, because with the tsunami of diabetes, you often see more than one family member involved. There's always family history in polygenic diabetes nowadays. But this is how what triggers me, what catch my eyes and trigger my suspicion of the LADA and MODY is the high postprandial excursion. Check the antibody C-peptide. This one negative, high C-peptide. Then you might try sulfonylurea, and the MODY actually shows a robust response. Glucose tend to go to 20 plus الحقيقة ورا الميل. بس تعطي small dose sulfonylurea, 30 milligram of diamicron, for example, and that will just stop it. So that's something to consider. And of course, I do ask them routinely, any newly diagnosed diabetes, do you have any hearing problem that would raise the suspicion of mitochondrial diabetes? Now, this is a busy slide of our algorithm. If you were wondering what's our algorithm, it is still stepwise consecutive therapy, not we still haven't adopted the starting combination therapy upfront. So it's still sequential, unfortunately, because the Department of Health, and I say unfortunately because the Department of Health, because I'm in favor of using combination if possible upfront. لكن the Department of Health budget ما تسمح لنا, and still direct us to follow a sequential approach. And now if you could see here that the sulfonylurea is actually first in the second line. So sulfonylurea is it's a time-tested drug. I know that the drug company is pushing towards these agents. However, the sulfonylurea in particular, do not take it off your medication. They are affordable. They are not expensive. We know their side effects very well. We had an experience with them for over 50 years now. So they're pretty good. يعني أدوية جيدة وكفؤة يعني رخيصة, وبالتالي كثمن, وبالتالي تساعد يعني ممكن تستخدمها المرضى وتقلل من كلفة العلاج على المريض. And in the algorithm, we opted that you can start insulin upfront if your A1C came up really high. Because of the hyperglycemic stunning effect on the pancreas, you might need to offload the glucose first with insulin, and then you can wean it off down the track. Or continue it continue on insulin. Lifestyle measurement, diet, exercise, weight control, etc., etc. Still there in our upfront, in our first line, our algorithm, which is excellent because we know now if you lose 15% of your weight, the chances for your diabetes to go into remission is more than 85%. Now, how to put these guidelines? So we start with the GLP-1s. As we all know, that the person with diabetes have generally lower level of GLP-1s than non-diabetic control. Now, GLP-1s are glucose-dependent insulin secretagogue. And what it does, if when you start the infusion, for example, of the GLP-1s, it will stimulate the insulin to go up. It will reduce the glucagon, drop down, and of course, it will bring the sugar down. However, at a certain point when the sugars start to get close to hypoglycemia, the increment on insulin stops, plateaus, and the glucagon started to go up. And by doing so, it will it doesn't usually, hardly ever causes. A 63-year-old woman, patient age, 5 years history of type 2 diabetes, diabetes age, and the following complication: TIA, stable CKD, proliferative retinopathy with an A1C of 8%. And would you consider GLP-1 receptor analog? And I think we need to consider, maybe we need to be cautious with using these analogs in this group. As you know, in the two studies, including semaglutide, dulaglutide, they both show increased risk of retinopathy. And they assume the reason behind the drive for that risk increment was related to precipitous drop in the A1C. The A1C dropped too low, and that's been shown with other agents in historical papers. ولكن GLP-1 receptors is present in abundance in the retinal vessels, so that we do have concerns with two different medications. They both cause the same problem. That raises suspicion, and therefore we prefer to switch them over to SGL2, لأن ال SGL2 inhibitors مثل ما تعرفون حضراتكم هي تمنع complication retinal, يعني it can provide retinal protection against retinopathy, both primary and secondary, particularly secondary عفوا. With regard to GLP-1 receptor analog, this is another case of a 50-year-old male with uncomplicated type 2 diabetes for 9 years. Now, again, if you appreciate that this is the stem, how I present the cases, patient age, the age of the diabetes, and whether or not there's any complication. And now this patient has a high BMI and adopted to start semaglutide. What sort of side effects I would discuss? We expect the patient to develop nausea with the semaglutide. Usually, this nausea will subside in the subsequent weeks. Vomiting can happen occasionally, usually in the first day or two after the injection, and occasionally abdominal pain. I tend to stop the drug if the patient develops abdominal pain, because this could be an indicative of pancreatitis. Vomiting is not enough for me to stop the medication unless and until the patient has daily vomiting throughout the week after the injection. You could say, side effects or pancreatitis, but what I say is difficult to ascertain, لأنه حتى من قياس lipase والamylase, it will be high in an asymptomatic patient on this medication. ولكن my argument is it will be very difficult to ascertain between the two diagnoses, but it's very difficult to continue to كيف تقنع المريض انه يستمر بعلاج يخليه يتقيد بشكل يومي. هذا مو علاج. Okay, so this is my reasoning to stop the medication, but usually 1 or 2 days after the injection they can have some degree of vomiting, usually mild to moderate, nothing profound. So in these circumstances I like to continue. 71-year-old patient age with 10 years history of type 2 diabetes age, and complicated by peripheral neuropathy, and she was treated with semaglutide alongside metformin and Ryzodeg, and she presented to her GP with vomiting about 3 times a week, and the GP checked the lipase and was more than 3 times upper normal. So that was quite significant, and I had to stop her. Of course, there's semaglutide, someone with vomiting and very high lipase. I thought this may well be pancreatitis. Now, if I would do a CT scan, I don't think it will help, because the pickup with this mild pancreatitis, the pickup rate for CT scan to get the strangulation, often the stranding, the peripancreatic fat stranding is actually pretty low. So I just had to stop it. But again, she came to see me to see, now the amylase and lipase has normalized, I'm not symptomatic, and I like to go back on the injection, and I definitely advise against any insulin secretagogue, and instead I suggested you can take SGLT2 or insulin and metformin, but any medication, even sulfonylurea, in this practice. And in the past, we actually used to give, if someone developed pancreatitis whilst on sulfonylurea alone and metformin, once the pancreatitis settles, we can reintroduce the sulfonylurea. We do that. نقول له نوقف التدخين وما إلى ذلك، ولكن يعني نقول إنه لازم يعني يقلل وزنه، يوقف التدخين، يمنع الشرب إلى آخره alcohol. So لكن فيما يخص GLP-1, once they have pancreatitis or DPP-4 inhibitors, we do not re-challenge. They are no longer safe to take any medication that stimulate their beta cells or the SNF cells. This is a study that explains what I said. It was done by Butter Excellence, very small number of patients, 6. He chose historical non-diabetic post-mortem and look at the pancreas of those who had no diabetes, beta cell, and alpha cell, of course, and those who have diabetes without incretins, and those who have diabetes while having incretins. And you could see that the beta cell gone up mass and the alpha cell equally, well, as well. They both gone up when you have incretins, and that's very peculiar. We know in rodent model that the incretins, in particular DPP-4 inhibitors, tend to preserve beta cell. But what this guy did, he looked at the KR67 and seems to have gone up. So there is a proliferative beta cell, and we know that beta cell doesn't usually proliferate as we grow older. What he found is that there's a marker for dysplasia, dysplastic hyperplasia. It's called IN1, and that's gone up. So I think the hyperplasia in the beta cells, while this on board, is not the usual normal one. Okay, so this raised, and there's quite few studies in rodent model that corroborated these results. So it's something, that's why we don't dare re-challenge the patient with the DP4 inhibitors or SGL or the GLP-1 receptor analog if they have history whilst on this drug, or even had a recent history of pancreatitis, regardless the cause, because we know they promote dysplasia, pancreatitis, beta cell dysplasia. So the definition of pancreatitis, raised amylase and lipase, that's expected within insulin secretagogue, more so with GLP-1 receptor, and we don't have a good criteria, and we don't use amylase and lipase as a criteria for diagnosis. And I have seen what we call it amylitis. I've seen patients who have raised amylase consistently, and they're not diabetic, and the reason why they're having raised amylase maybe from the saliva gland, another route for amylase. And the symptoms, it can overlap between side effects and pathological disease. So there you go. But they really shouldn't have abdominal pain every day. I'll give some scenarios of when do we use DP4 inhibitors. Someone who tend to wake up with high sugars, but they tend to drop hypo during the day because he's a laborer, يشتغل عامل. To avoid hypos, you can use DP4 inhibitors because they are euglycemic agent. They are unlikely to cause hypoglycemia. Someone who's fasting Ramadan, for example, taxi drivers, long hours drivers, truck drivers, because you don't want them to have hypos while they're driving. Sometimes الشخص من السيارة مسافة بعيدة يعوف الغداء، يعني ما يقدر يتغدى وكذا، يصير عنده هبوط مثل ما حضراتكم تعرفون، أنا متأكد وشايفين. Now back to SGL2 inhibitors, an example. I thought, حقيقة بهاي الexample show you not when to choose the medicine, but not when to avoid in our practice. So this is a 62-year-old male with 15 years history of diabetes. تلاحظوا أنا كيف استخدم هذه الستم. عمر المريض، عمر الدايابيتس and complication مالته. عنده diabetic foot ulcer which has vascular component and neuropathic component. Would you consider SGL2? I think it's well here in my apologies. We actually look at it as we in our practice, when it comes to active diabetic foot ulcers, not someone who had a history of diabetic foot ulcer, it's a relative contraindication. And those who we stop the SGL2, those, for example, who have an active foot ulcer that has a vascular component. We see every now and then some patients who have neuropathic foot ulcers with good peripheral pulses and circulation. Unusual, but we still see it. The neuropathic ulcer is not a contraindicated. It's all, evolve over the fact that the SGL2 inhibitor, we think, adversely affect the peripheral circulation. We don't know exactly why, presumably through heme concentration, which you actually cannot get for some bizarre reason with the diuretic. So we don't know the mechanism, but that's what we do now. Active foot ulcers with a vascular component to it, we tend to withhold, stop it until it's healed. Now, practice point, another patient who has 69-year-old, diabetes for 7 years, non-ischemic heart disease, microproteinuria. Recently started on SGL2 inhibitor. How would you assess the patient after you start? How can you tell they have ketosis or not? You have to ask them. We don't routinely check the ketones, blood or urine after SGL2. We do not and should not do that. You can ask the patient if they feel unwell. Those who have developed ketosis, they actually tend to be symptomatic. They do feel tired and exhausted unusually. So that's when you check. And the other thing I will ask that patient is if they develop any candidosis, any genital thrush. Now, neither of these conditions are contraindicated. Neither of them is contraindication to re-challenge in the future. I have quite a few patients who had genital candidiasis, and once treated, I stopped the medication, treated, and recommenced. And usually those who have chronic dry vagina or vaginal atrophy, or those who have very high sugar at baseline because they tend to pee out more glucose. Now, we move on to a different point, domain in today's talk, and we're nearly finished, in hypertension and diabetes. There's few specific features of high blood pressure and diabetes. If you have hypertension and diabetes, the mortality goes up by 40%. So it's more than having one of the condition and not the other. In terms of pathophysiology, the hypertension in this group of population, they tend to be more variable, it tend to shoot up and less likely to dip overnight. So that's a bad thing because of the autonomic dysfunction. It's also associated with quite a bit of glycated collagenopathies, as you would expect, and with more endothelial dysfunction. So generally speaking, our target, back to the practice point, between 120 and 140 systole and under 80. And this very important point I'd like to mention, I'd like to share with you, is sometimes when you bring your systole pressure to target, the diastole drop to 60 and 50. And there is a study done in the past that showed that the diastole drop below 70 increases cardiovascular mortality. And turned out to be the reason why they increase mortality for those who dip their diastole below 70 is because they vasculopath. So it's not lowering the diastole directly cause the cardiovascular outcome, mortality or morbidity, but the fact that they have a poor vasculature at baseline, that's what caused their death. فمثل ما قال أحد الأساتذة في أحد يعني المؤتمرات إنه once the diastole drop below 80, it become a nuisance. يصبح إزعاج. Don't worry about it. Okay, just bring it under 80 and it doesn't matter how low it will drop below 80, 50, 60, don't worry about it. And of course you need to get the systole under 140. If they have, as you know, some microvascular, in particular in the nephropathy, protein-losing nephropathy, then you might need to get the systole between 110, 120 and 130 and no more than 130. So you have a room to further intensify your medication in certain groups, high-risk groups. Now, there's a concept that I'd like to share with you here is the aortic root stiffness in the obese, not just in the diabetic population. It actually, there's a study showed that actually precedes the diagnosis of diabetes by about 10 years. Precedes the diagnosis of peripheral hypertension by 10 years. And that's why diabetic hypertension is predominantly systolic. And therefore, if you read someone blood pressure reading and you don't know, shall you not start 120 systole, 125, 130, shall I not start? I would start, because I know the aortic root has already become stiff, and I don't want too long to start treatment. Start early if possible. I think that's the message I want to pass over today. Now, this is a question for you to answer with yourself. If you have someone with diabetes and the diastolic pressure which dropped, you managed to bring it down from 85 to 81, would you think this will improve the cardiovascular, prevent cardiovascular events? The answer is yes. And if so, if you bring the diastole from 85 to 81, how much the cardiovascular benefit you will get within 2 years' time? 50%, 30, 20, or 10? You'll be surprised to hear it was 50%. This is the hot study here, and you could see in the diabetic population, when they drop the diastole, that's after adjustment for the systole, when they drop the diastole from 85 to 81 to 83 in one group and 81, and you could see the number of events per 1,000 patient years. It dropped down from 25 to 12.5, so that's 50% relative risk reduction just by bringing the diastole from 85 to 81. Why am I saying bringing this down? This is a small study, about 600 plus patients, and it's an old one, 98 at the Lancet. It's just to show everyone the importance of bringing the diastole below 80. That it also does play a role in the cardiovascular. With my last case vignette here, a 45-year-old young man with a 7 years history of uncomplicated diabetes. Again, I'm sorry I have to say this again. Patient age, diabetes age, whether or not it's complicated. Currently on metformin, or have been on metformin and sulfonylurea. A1C has gone up to 8.2, but if you look at their file, they usually run under 7.5. What do you think we should do? I think we need to look at Mark Twain suggestion here. The only way to keep your health is to eat what you don't want, drink what you don't like, and do what you would rather not in terms of exercise. So before, usually the patient neglected themselves. That's where the sugar has gone up in a very short period of time. So the historic, the last slide, I just want to say that the lifestyle modification is the first thing we need to think of when we assessing the patient glycemic control. I'll stop here, and I'll hope to see you soon in our May's endocrine grandchild. Thank you all.